What makes the MRI scan important in multiple sclerosis? First of all, it's a very important tool in reaching the diagnosis at the outset. After starting a treatment, it's an important tool for following the disease and making sure that the drug is working appropriately. Dr. Scott Newsom will describe how he uses the MRI to best diagnose and manage people with multiple sclerosis.
Hi, my name is Scott Newsom. I'm a neurologist at Johns Hopkins Hospital within the MS and Transverse Myelitis Center. I'm here to speak about the utilization of MRI. Now, most of you probably are aware that MRI has been around since the 1980s, but really when we think about its utility in multiple sclerosis, it's really something over the last decade and a half that has gotten more attention. And if we think about MRI in general, at least from my perspective, I feel that it's really the most sensitive tool that we have in terms of not only helping aid in the diagnosis of multiple sclerosis, but also monitoring MS over time, whether you're on treatment or not. Now, we know with MRI, at least early in the disease course, there's a lot that's happening behind the scenes. And that is actually very important to understand because just in the cases of individuals who are not having clinical relapses or disability progression, there could be a lot that's happening on MRI. And so nowadays, many clinicians in the community and academic centers are doing imaging more often than we used to in the past. Why should we care about doing MRIs in multiple sclerosis, especially after we've established the diagnosis of MS? In the past, clinicians would actually not do MRIs, and they would wait till someone had a clinical attack or exacerbation, then they would do an MRI at that time. But what we found from several studies over the last decade or so is that the MRI is highly predictive of future disability and inflammation that we see in multiple sclerosis. I can recall one study that looked at patients who are on a specific treatment regimen and 1 year out on that treatment regimen, showing that the MRI was highly predictive almost 5 years later of disability progression. And that was irrespective of a clinical relapse, so separate from a clinical relapse. And I remember way back when my mother had multiple sclerosis, and this was in the time where MRIs were not utilized that often. And going to her appointments with the neurologist, I would ask, well, yeah, I understand that she's not having clinical attacks, but I heard of this thing called MRI, which I wonder, is this something that we could use to monitor her outside of just how she's doing clinically? Because I've observed at home that there are some times that she's not doing very well, even though she's not having these fulminant relapses. So that, for me, was sort of the start to having a understanding of maybe how powerful MRIs could be. Because I feel that actually in at least my mom's situation, because she wasn't being monitored like we do now, that some of her disability that accrued could have potentially been prevented vis-a-vis following her very closely with MRI. There are a number of clinical and paraclinical factors that we look at in determining whether someone has an aggressive form of multiple sclerosis. And with respect to the paraclinical factors, most of it is looking at the MRI. Now we know if someone presents with their first clinical attack of MS, maybe it's optic neuritis or transverse myelitis, and they have a very high lesion load from the get-go, multiple GAD-enhancing lesions, and also the area of lesion location, like if someone has a lot of spinal cord lesions or brainstem lesions, that is a bad predictor of the disease moving forward and gives us a flavor that this person's going to be in trouble unless we really shut down the inflammation that's associated with the disease. And so for many of us, we will look at the MRI and say, okay, we're going to use this particular medication that may be higher potency than we would otherwise based on what we see on imaging. As I mentioned previously, my mother had multiple sclerosis and was not monitored closely with MRI. And I can tell you, even today, this happens, even despite all the knowledge that we've gained from studies showing how highly predictive MRI is for future problems in multiple sclerosis. And I can recall a couple instances in my own clinic where one particular gentleman who is young, African American, came into my clinic in a wheelchair, and he must have been probably in his mid-20s, on a therapy, but going through his history, I wanted to get an idea of why he ended up with so much disability in such a short period of time and at such a young age. And interestingly, he was one of these individuals that had pediatric onset MS, and so in his late teenage years, he had his first clinical attack, and it was a spinal cord attack, left him with a little bit of leg weakness, which he recovered from. He was started on a particular medication, and that medication actually helped prevent new things from happening for an extended period of time. And he was a young guy in his early 20s and thought, well, I think maybe I'm cured from this disease because I haven't had anything happen. I'm back to my sort of pre-first attack baseline. I'm just going to stop taking this medication. And so on his own, without taking to advice his current neurologist, he ended up stopping the medication. And then literally within about a year to a year and a half, he went from walking to a wheelchair because he just had an excessive reactivation of his disease that landed him in a wheelchair. And so when I saw him, we had discussed, the importance of these medications that are out there, where we have a lot of clinical trial data supporting how they can prevent new things in MS, not only relapses, but MRI activity. And there's this clinical sort of radiological paradox that can happen with MS, especially early on in the disease, where the person feels fairly well. They're young, they have high neurological reserve, so they can compensate for the disability that may ensue later on. And as I mentioned before, there's a lot that's happening behind the scenes, which that's the clinical radiological paradox, where clinically they feel great, MRI looks terrible. Looks like a Christmas tree lit up. And the challenge that we have is we have to really impart this knowledge on patients and other clinicians who are not using MRI as heavily as maybe myself and colleagues of mine. Because what's happening behind the scenes is really critical to what may be the person's future from a disability perspective. In my view, I actually feel that it's malpractice not to do MRIs, especially early on in the disease course of multiple sclerosis. And you heard me speak a little bit about my mother's situation and the patient that I just described. And I know anecdotally, at least in my own clinic, I have seen patients where we've taken the opposite approach, where we've been very aggressive in monitoring people up front with MRIs and seeing what's happening on MRI and actually making a change in their treatment regimen, even though they may feel well. And I can tell you from my own experience, and I think this is supported now by studies, that treating MS earlier and more aggressively, for some, not all, but for some, may put them at a better spot long term. And now I've been doing this for a little while, and I've seen that in my own practice. And so we are big believers in using MRIs. And the other thing too is we don't want to blame everything on multiple sclerosis. So I've also had individuals come into my clinic where they've had worsening in their MS. And everyone's blaming it on their MS, and maybe they haven't had an MRI recently, and we end up doing an MRI and we find non-MS related pathology, most commonly degenerative disc disease, spinal stenosis, that's actually causing increase in their disability, which, in that setting, you could imagine a scenario where someone's escalating their MS therapy to potentially a dangerous drug or a more dangerous drug. And they're doing this on the auspice that it's actually their MS that's worsening, and here it's actually they have spinal stenosis that's causing their disability. So I'm a big believer in re-looking at things, including repeating imaging when you feel like, oh, is this MS related or not? And that's the same, even though I'm speaking on MRI, we also will do this with laboratory studies, where once in a while we'll go back and say, oh, let's check this person's B12 level, make sure that that's not driving some of their disability or rheumatological panel. So always got to put a question in your mind to say, okay, is this all MS related or not? And again, as I mentioned in the past, that MRI really is the most sensitive tool that we have, not only in helping aid the diagnosis of MS, but also to monitor the treatment response and just to monitor the disease over time. So what can you as a patient or a clinician do if, let's say, you haven't had an MRI in a while, or an MRI hasn't been ordered on a patient that you're seeing in a while? Another scenario that may come up is that you ordered an MRI and it gets denied by insurance companies, which actually can happen quite often, especially if you're doing more than one MRI in a year. And so I encourage you to be an advocate for yourself. If you're a clinician, be an advocate for your patient. I can tell you personally what I've had to do with insurance companies is write a letter of medical necessity saying why we need this MRI done, even though this person just had an MRI 6 months ago. And I'll cite literature showing how predictive MRI is, especially when someone starts on treatment. And so you have to be an advocate for yourself, and again, the clinician has to be an advocate for their patient. MRI has become, in my mind, a cornerstone paraclinical testing in the comprehensive care model of multiple sclerosis. As I mentioned, it's very useful for making a diagnosis, but it's also extremely useful to monitor people over time. Recently, there was a consensus conference meeting held through the CMSC, which brought experts around the world, both radiologists, neurologists, and others, to look at where we are with MRIs here now in 2016, 2017 versus 10 years ago. And what came out of that meeting and a few other meetings, very nice information that's useful for clinicians and patients to follow in terms of how often should we do MRI, especially early on in the disease versus, if you've had MS for a while, if you present with a specific phenotype of MS, like an aggressive phenotype versus sort of a milder variant. And so these are helpful tools that have been published and they're online for access, which I really endorse and I sort of advocate for people to look at that if you're not familiar with how we're doing MRI monitoring in multiple sclerosis currently. Why is that important? As I mentioned earlier, there's this clinical radiological paradox that happens in multiple sclerosis, especially early on, where there's a lot happening behind the scenes on MRI, even though the person feels fine. And I've had the situation come up where, you see the MRI of a patient and it's like a Christmas tree just lighting up. And then you talk to the patient and say, are you sure you're not having any new symptoms? Fatigue levels are the same, cognitive function is okay. You do their exam at the bedside and it's completely normal neurologically, and there's this big disconnect. As I mentioned though before, that is someone who's going to be in trouble long term. So we want to be aggressive in thinking about not only doing MRIs, but if we see that patient is clinically stable, but the MRI looks terrible, we may want to think about changing their treatment or getting them on a treatment. Why is it important for us to really utilize MRI more often than we did in the past? I think I've mentioned to you multiple times, like a broken record, this clinical radiological paradox. The challenge that we have is once disability is fixed in MS, at least currently, we do not have treatments that can reverse that damage. So we have to be proactive, we have to be preventative. And some of that prevention is seeing what's happening on the MRI and making treatment decisions occasionally based on just the MRI. And so we want to really prevent new things from happening so we can prevent long-term disability. And I think some of the studies that I alluded to earlier are giving us a window into, yes, MRI is extremely important. It's one of the most sensitive tools that we have to monitor this condition. And so MRI, in my mind, is